Hello everyone, welcome to the NK Active Podcast, episode 5. Really hope you enjoyed the last episode with myself and Caroline French from WJ French & Sons, chatting all things footwear. So today we have Charlie.
Hello.
And then we have Natalie.
Hi.
Everyone should know who these two are by now, that they've been on the podcast enough with me already. So let's this month chat about all things related to heel pain, because heel pain is, as sort of podiatrist myself, is one of the most common causes of foot pain that we see in clinic, and everything just gets lumped with the term everything's plantar fasciitis. But as we'll discuss later on, there is so much more to heel pain than there is just plantar fasciitis. So I think what we'll do today is we'll have a chat around like the most common types of heel pain we can see in clinic. Then we'll at the end have a discussion about some of the rarer ones, some with some strange names. And then we'll then start giving you guys some tips on what you can do to try and then manage this yourself. So let's get started. What should we start with first? Let's scroll down to my notes and let's start with plantar fasciitis. So Charlie, talk us through about what is plantar fasciitis.
So plantar fasciitis is the structure that we call anatomically is the plantar peroneus, and it's a really fibrous, thick tissue that starts at the heel and then goes along the arch of the foot and inserts into the toes. And this is the structure that we use every single time we take a step, and it acts as a bit of a spring. So it kind of holds energy and then releases energy and force to be able to help with movement. And so what we're finding with plantar fasciitis is that if we're overloading the structure or there is pathology, so change in that tissue, then what this can then lead to is symptoms of pain and discomfort.
Okay. And then with regards to that, is the plantar fascia just a continuation of the calf muscle and the Achilles tendon, or is it different in people?
I think that's a really good question. So I think there is a separate structure, so it's its own anatomical structure, but actually it works really closely with the Achilles tendon and calf muscle to help with movement and performance in running and walking. And so it's not just necessarily focusing on the individual structure, but working with the ankle and the knee and hip to then get that whole motion together. And I think that's what we miss out in clinic, is we concentrate so solely on the foot and ankle that we forget that it's connected to a larger set of joints and bones that move.
Yeah, no, but this is why, even though me and you are podiatrists, we'll often see foot up to hip issues, because as the old nursery rhyme, is it a nursery rhyme? I don't know, the Funny Bones, the TV show that Natalie's actually too young to remember what Funny Bones was, the word the foot bones connect to the ankle bone. I'm not going to sing it, don't worry. So then, yeah, because I agree with that, because I have seen from some anatomy textbooks of cadavers. So cadavers, for people that don't know, they're basically people who have kindly donated their body to medical science, so we can help actually learn what anatomy is, because there's no better way of learning than from a human body. So I've seen in some textbooks where actually you see this small bit of fibrous tissue that comes from the Achilles and it goes round into the plantar fascia. However, I've then also seen some where it isn't there at all, and it's just the choice of that anatomical variation. We're all different, even when it comes to anatomy.
And it makes sense, doesn't it? Like, it's a really strong structure that has to hold your body weight and then move it as well at sometimes high speeds and force. So it's going to have to be a tough little structure, and everything has to work together. So I always think of like the lower leg as a bit of a car engine, that there's lots of little pieces that come together to form movement, and that's the same with the foot and ankle. It forms a larger part.
So then what do you think it is? Again, going off script again, are we going to call it fasciitis, osis, opathy, or are we just going to call it sort of plantar heel pain?
See, I quite like the term plantar heel pain. I think it allows that encompassment of all the pathologies and all the variations of people that we see. And yeah, I think that's a very fitting title.
I agree. That's why, because it's not all the time, it's not chronically thickened. It's something there's not an inflammatory component there to it. So we can't always call it isosis. We can't always call it plantar fasciitis because it's different. So then I think when you then start looking at this plantar heel pain, and then if you look at the subcontext of that with regards to sort of the plantar fascia issues, in sort of my opinion, there are sort of three different sort of stages of it, as it were. So we'll get Charlie in a minute to chat about the imaging side of things, but what you could have is aggravation or thickening of the plantar fascia, then that may be causing your symptoms. But then you can then also then get aggravation of the fat pad, which is this big sensitive tissue that sort of sits around that, underneath that plantar fascia, on top of that plantar fascia area. And then you can then get something called bony edema, so bruising of the heel bone itself. And I've seen cases of sort of this what's been labelled as plantar fasciitis, where they've got 1, 2, or 3 of all these things, and they will all present in different ways. So if we talk about your stereotypical textbook plantar fascia issue, you'll have that first step pain in the morning. You take a few steps in the morning or after rest, and then it eases. If you've aggravated your fat pad, you'll tend to find long periods of standing around and not moving will just give you that intense, sharp pain. And then if you're then getting that bony bruising, you'll then find it will start aching and throbbing at night. And you could have one of those elements, you could have all three. And I think depending on how many of those are present could then affect how long it takes to get better. So if we then talk about imaging, Charlie, sort of if someone was to do an image of this, what would you expect to see on, say, something like ultrasound, for example?
Yeah, so ultrasound is commonly used to assess kind of the plantar fascia tissue, and we tend to take an image from the heel bone, and what we're looking for is thickness. So the literature states that if there is an increase between 4 and 6 millimeters, and it's different from the other side, saying that they've got symptoms on one side and not the other, then it can lead to the idea that there may be pathology. I guess this is where the world of research, we still need to keep adding to this knowledge base, because we know that if you're actually doing activities that are going to be strengthening and adapting that structure, then theory would state that you're going to see these natural changes in tissues. So it's actually becoming harder to specifically provide real definitions. And I think that's what we need if we're going to start using imaging, is to be able to go, right, what are the definitions for these different populations of people who have plantar fasciitis or plantar fasciopathy or plantar heel pain, and what does that look like? There's been lots of work done in Australia looking at MRI imaging, and they're looking at different characterizations and characteristics that we're starting to see. And it's looking at what does that add to your treatment plan and treatment diagnosis. Is it used as an educational tool to support patients to understand their condition, buy into why we're doing the certain things that we're asking them to do? Does it change what we're going to do in terms of a treatment plan? So imaging has its place, but it's being really mindful that we still need to work quite hard to work out what it means to that individual person. And I think that's where it's really tricky.
Yeah. And so to sum up then, really, is if you've got this plantar fasciitis, plantar heel pain, not everyone needs to have an image to actually then get to that diagnosis, because a lot of it is in the history. And then sometimes the image that you get will not always then correlate to the problem that someone's got.
Yeah, and I guess and for someone like myself who researches imaging and anatomy, this is the amazing problem to sit and solve, is why doesn't it present and look the way that we think it should do?
Yeah. So now let's move on to a treatment kind of thing. So we'll have a chat through all different types of treatment, but let's start from an exercise viewpoint. So Natalie, you've rehabbed a few of these by now with us in clinic. Do you think if you rehab more plantar fascia issues or more plantar plate injuries?
Oh God, plantar plate.
Yeah, definitely. It's still the most common problem I personally see.
100%.
So then talking about the exercises around sort of helping someone who may have this plantar heel pain, we'll just call it plantar fasciitis for the rest of the podcast. I think that's just going to be just easier for people. So what sort of exercises would we be looking at doing?
So one of the main ones will be sort of calf Achilles going into that sort of the foot, so heel raises.
Yeah.
Now the problem with heel raises is sometimes it can put it on stretch, and we see a lot of patients who are unable to do this. So what we do is we have like a foam dome almost. So we call it the plantar pad. And we just pop this underneath the toes, the base of the toes, and we get the patient to do heel raises from there. And it does sort of reduce pain, but it allows us to work and work those calf muscles as well. Obviously, like any program, starting off double legged and then going to single leg. And then we also focus on that proximal control. So a lot of sort of squats, lunges, again going to single leg squats, going to lunges, focusing on knee control, so band walks, sort of hip, outside of hip, inside of hip, and sort of progressing that way. And then eventually going to sort of hopping exercises to making sure that band's really working, and it's sort of using that elasticity that Charlie was talking about when we're walking and running and stuff. So we get people back that way.
Okay. So going back to the use of that plantar pad or the Fasciitis Fighter is another one that we can use as well. What's different about doing a calf raise with your toes sort of on that with a raised up position compared to just doing it flat on the floor? Like why would we want to try and do that with someone with plantar fascia issues compared to just doing a normal heel raise?
Yeah, it takes that stress off the load, off that band, so it just allows more movement to be had with less pain.
Yeah.
And we also, if people don't have plantar pads, we can sort of roll up a towel and use the same principle as popping it underneath the toes and then using that as a...
Yeah, we started using pads, towels. The issue I found with towels, people, it sounds silly, but people just didn't roll them up. They just got bored of rolling. And then after 2 or 3, it just compresses far too much. But luckily, with anyone that goes through our sort of rehab package, they'll get a plantar pad or Fasciitis Fighter as part of that. And there actually is some research behind using the Fasciitis Fighter. So there was a researcher called Michael Ratliff who looked at the study, and basically, we know doing that, in theory, you transfer more of you target the fascia slightly better than compared to just doing a heel raise on the own. Now, the research is very much in its infancy, but it's something that we use a lot in clinic, and I think it is making sure you get that right sort of type of patient with it. But also, we're quite progressive in that we will sort of load people up quite heavy with it. And then, so we're talking about then working on the gastrocnemius. So there are any other muscles in the leg that we would tend to try and work on with these plantar fascia syndromes?
Yeah, so the soleus as well. So the muscle that sits underneath your main calf muscle. And we do this through seated calf raises. We're lucky enough to have a gym here, so I can do it on the Smith machine or on our soleus calf machine. But again, if people don't have this at home, I get them to sort of sit there, get a washing basket and just fill it with everything. Wine bottles, baked bean tins,
children.
Anything. Yeah, dogs, anything. And they get that same load going through, but with the seated.
Yeah, and I completely agree. I think the soleus is most probably in the lower limb, the area the muscle that's forgotten about the most, I think, when it comes to rehabbing, particularly these plantar fascia issues. So I think you then also hit on the point there nicely of you're building up that strength to begin with, but then it's then building up that sort of elasticity and that energy storage back to then moving on to the hopping, which I think again is really important, because effectively if someone's a runner or they play any sort of basketball, dancing, you don't just walk around playing those sports, do you? So you need to get the structure ready to go back. So that I completely agree.
Yeah, and what better way to test it than when we're here and we can see someone doing it, and then if it's irritated the day after, they can give us a call, and we can see how we can progress it that way in testing it. So
then other treatments that we may use in a clinic could be something along the lines of shockwave therapy as well. So Charlie, talk us through about how we've been using shockwave therapy in clinic and some of the results we're starting to see with it?
Yeah, so shockwave therapy is using kind of a pressurized force to place it on the area of discomfort, with the idea being that it creates, well, it encourages an inflammatory response to take hold, and the idea being that once you've done the inflammatory response, that it will start the healing process and provides us with a window of opportunity to then start to work on some of the rehabilitative stuff and use kind of things like orthosis and strapping to just kind of help make the patient comfortable, but yet work on function and mobility.
Yeah.
And what our data is showing is with the shockwave is that it does actually, in those patients who are in quite an acute phase, that means they're in quite a bit of pain and discomfort day to day, it is allowing them that window for a few weeks to be able to really home in on some of the exercises that they're going through, and to really just start to settle some of those symptoms down. And so what we're noticing is that their pain reduction is happening quicker, and therefore they're able to do a lot more or tolerate a lot more in their kind of working week.
Yeah.
So it's been a really useful tool for the short term to then help us build long-term goals with our patients.
Yeah, I think that's definitely sums up nicely how what we've been seeing in clinic. Though I'm not convinced. I think if you look at a patient 12 months down the line, one had shockwave and one didn't. We don't know yet, but my initial thoughts are that the patient has shockwave and the pair that didn't will be in the same position. But I think that journey to that 12 months will happen a lot quicker with the ones that combine the shockwave with the rehabilitation exercises as well. So you mentioned again foot orthoses. Sort of, do you think we need to give everyone who has plantar fasciitis foot orthoses, or is it more on a sort of a case by case basis?
I think it's case by case, and it's looking at whether plantar fasciitis or plantar heel pain is with coexisting with other pathology. So sometimes maybe forefoot pathology or foot in the midfoot area can then aggravate the heel. So it's looking at what is the patient's kind of clinical history and presenting symptoms. So for those that have lots of different things going on, so sporadic foot pain in different areas, I find orthosis again, we don't ever have them for long term. It's more of a short term intervention. Again, provides us with that window of opportunity to then be able to start to work with that patient to resolve some of their symptoms, improve pain, function and mobility.
And do you know what? I think that will make another great podcast. Is actually, we could do one on myth busting around foot orthoses, and you just raised a valid point there of that not all orthoses have to be there long term. You can remove them and they could just be there to help and aid that rehabilitation process. So then with them foot orthoses, the other things we can look at doing is then also taping. And you can use, I personally, we like here to use the zinc oxide, the rigid stuff, not the flexible K taping. We just find in our hands, we just don't get good as results.
Dangerous.
Yes. But also what we can use the tape for is we use it a lot of the time, because I call it the get out of jail free card. It can really help reduce symptoms there and then. It's not a long-term thing. Taping is just a short-term sort of solution, as it were. But also, sometimes you can use it for, do you think actually, is this person going to benefit from any sort of foot orthosis? The way you tape your foot, you could almost try and mimic the prescription that you then may use in the orthosis, and you can then try and then work out which people are going to be suitable to an insult. Because I completely agree, not everyone with plantar fasciitis needs an insult, and actually the majority of them don't need anything long term either. A lot of it is just about just getting stronger and building that tissue capacity. But we'll pop a couple of links in afterwards, because we've got some YouTube videos of me taping, I think Natalie's heel it was, and then me taping my own heel as well. So we can show you how you can do it at home, and then we can also put in some links to our sort of NK Active shop where we sell like the tone loops, the tape, the Fasciitis Fighter. So trying to then bring sort of plantar fasciitis to an end and moving on to the other one. One final thing, Natalie, is if you think someone has got this, what are sort of your mostly 3 best self-help exercises someone could do at home, whether they've got a Fasciitis Fighter or tape or not? What would your sort of be 3 most go-to exercises?
Probably the heel raises with the towel or plantar
Yeah.
pad. I
Yeah.
find that helps a huge amount. Next one will probably be more proximal, so I'd go for like a band walk to
Yeah.
work the glutes.
Yeah.
And then the final one would probably be, depending on where you are, if you're earlier on, probably the seated calf raises for that soleus,
Yeah.
with heavy weights. And then if you're later on, the sort of box jumps to get that elasticity back.
Perfect. And then Charlie, for you, sort of 3 tips that are non-exercise based for someone. So things that they may they can do to help themselves, or when's the point do they then need to sort of go and find someone to get some help with this?
Yeah, so I think taping sometimes in the short term for kind of 2 to 3 weeks is really great to use. I tend to use a lot of the taping when there's always an event. Just the weekend before is when you always pick up an injury. So that can sometimes just allow you to get over the threshold to be able to do the event that you need to do and then go and seek help after that event. The second thing would be looking at footwear. So a shoe that's a little bit more stiffer in the sole and supportive, so it's not easy flexible, can just sometimes help support the ankle and the foot in the short term. And then other things, you can get kind of off the shelf arch supports that can sometimes help with foot function and mobility, but in reality I think it's looking at what you want to achieve. Having a diagnosis, having someone assess and make it targeted to you is what will get you better quicker and help resolve symptoms.
Perfect. So now let's move on to our next one of common causes of heel pain we see in clinic. And this one's more around the back of the heel. So that plantar fascia is on the bottom of the heel. This one's more around the back. And we're going to have a chat about sort of 2 for the price of 1, really. Insertional Achilles tendinopathy, and then also calcaneal apophysitis, which is commonly gets the name severs, which you see in children. So if we start off with that insertional Achilles tendinopathy, if you sort of think of the Achilles having sort of, you've got that the gastrocnemius, soleus, then it goes into that Achilles tendon, and then you've got sort of 3 parts. You've got the point where the muscles start and turn into tendon, the tendomuscular junction. Then you've got the body, the bulk of the tendon, which is called the mid portion, and then you've then got the bit that then it sort of fixes itself to the heel bone, and that's called the insertional part of that tendon. So if we then sort of think about why do we see those coming in clinic, a lot of the time it is sudden changes in activity levels. We've also seen it in our more running triathlon population, people who have changed from a shoe of, say, a 12 mil drop right down to a minimalist type shoe. We tend sometimes to find that they aggravate the insertional Achilles, but a lot of the time it is related to just not having what we call capacity in the tissue, i.e. you've done too much and then the body can't cope with the load you're trying to put through it. And then also you have to keep in the back of your mind, the more rarer cases, you can then sometimes get insertional Achilles tendonitis, which is then more related to systemic problems like rheumatoid arthritis, for example. But we're mainly going to focus more on the sort of the tendinopathy aspect, the overloading issue, as it were. So, Charlie, what can we do to try and help treat this insertional Achilles tendinopathy?
Short-term intervention can sometimes be placing what we call a heel raise into the shoe. So this is just looks like a bit of a wedge that you put in the back of the heel that can take some of the load forces going through the Achilles. And again, this provides a window of opportunity to then work on some of the strength if that's an issue, or sometimes the flexibility if depending on what your clinical assessment findings are. We do sometimes look at footwear and look at maybe if you want to go from a high grade, a high heel height to a lower heel height, it's that gradual change over time, rather than that instantaneous change that occurs. And then it's also looking at your load management throughout the week. So what is it that you're doing in your day that's potentially building that capacity and load through that tendon? And is there subtle things that you can do to make things a little bit more different? Are you taking more breaks throughout the day? Is it changing from walking to cycling to work? So that you are just being mindful of what the tissue's fatiguing throughout that day.
Okay. And Natalie, then moving over to you, exercises for these insertional Achilles and tendinopathy, what are we looking at doing? But then there's sort of a couple of things that we don't do because it will make it worse. So if you could just sort of...
Yeah, so tendons love to be loaded, so we load it as much as possible. Usually we ask the patient their body weight and we try and match that with weight in heel raises, squats, trying to load that tendon into that sort of dorsiflexion position, so that movement. And keeping on top of that the weights. Found so many people that get to a certain point where they're pain-free and their weight, their load is perfect, and then they decide because that pain is reduced, they'll increase their activity level but forget to increase the weight side of things. So I think for anything, I would say the loading is so important. Don't is stretching. So I see a lot of people come in like with doing wall stretches saying, I've stretched my Achilles, it's still bad. And this is where I sit on the fence with eccentric heel raises, because personally, from the people that I've seen, I've never seen any benefit from them whatsoever. So I don't tend to put them in rehab programs. But then I've heard, friends of friends saying that they really worked. But for me personally, I think because it's that stretching motion, I don't know.
So the reason behind that, and I think you meant plantar flexion, not dorsiflexion earlier, is that you will get that compression again. So if your heel drops down, you go into that eccentric phase, you get that insertional tendon compressing against the bone, and that's what they really don't like. So I would argue most probably your friends who may have not had insertional, they've more had mid-portion, which loves doing that kind of thing. But insertional, or they are insertional towards the end of that rehab program, not at the start, because that's the exact reason why you just don't incorporate the stretching, because it just won't like
definitely
that dropping down into that eccentric phase. Use it shockwave therapy. What do we think?
I love it.
Yeah.
I love it. I think especially with patients we've seen with reactive tendons, being able to do the shockwave first and then doing the rehab after, they're able to do so much more, and we're actually able to load the tendon without it being painful. So they get much more benefit out of it. That's sort of...
Yeah, and I've been shockwave for insertional Achilles tendinopathy. It seems to have gone around in a bit of a full circle. So to begin with, when I was speaking to the orthopedic surgeons and the sports doctors, they were like, no, we don't do it because it doesn't work. But now we're doing it and everyone else is starting to do it and combining of a rehab program, we're then starting to see it works better. But word of warning though, I think having shockwave on the insertional Achilles isn't going to be the most pleasant experience. It may be a little sore, maybe a little tender.
And I guess that's what we're doing here, isn't it? Is looking at what is the selection of exercises that we are doing in combination with shockwave of the Achilles to then look at what's working. And I think that's the gift that we can provide back, is starting to look at, right, what combinations of exercise and shockwave work well together, and what maybe less so. And again, that's that selection, isn't it? Right patient, right place, right time, when it comes to using the modalities that we have.
But I think that you both touched on a nice point there, because I think it's then everything that we do is bespoke to the patient in front of us. We're not just a tendon. We have a mind, a body attached to that tendon. There is a human being at the end of this ankle with this insertional Achilles tendon problem, and everything we do is sort of bespoke and tailored to that individual. And I think we can't pigeonhole people. We know tendons like to be loaded, but there are so many other factors we need to consider: diet, sleep pattern, that all has big impact. Of smoking all has big impacts on tendon health and rehab. How much time have you got to do exercises? All these things need to be taken into consideration. So if I was to ask myself 3 top tips for managing your own insertional Achilles tendinopathy, one would be, I think, go back and have a look at if there was that training error. Go back and did you decide that during the lockdown period you wanted to do the London Marathon because you thought it's the only chance I'm going to get a place doing London Marathon, do a virtual one, and then your running mileage massively increased? Was there a case of your dog walk increased, or was there a case of you started doing more hill walking or stuff like that? I think go back and and look at that. I think then also then start doing your calf raises standing straight to floor, making sure you're not dropping that heel down past that sort of horizontal level, as it were. And I think it's then sort of trying to get that mindset that these tendons, to manage them properly, they take time. There are no quick fixes when it comes to tendon issues, unfortunately. We'd love to turn around and say, we can do this, we can get everything completely better in 2 weeks. But we'd just be lying to you if we said that. And quick fixes just don't exist when it comes to tendon issues.
You're in for the long haul.
But our data shows that. Our data shows that if you're in for the long haul, and we then look at people once they've left us 6 months plus down the line, everyone's still doing pretty okay. People aren't coming back with their flaring up of injuries, which is absolutely
We've even seen some
fabulous.
successes, which has been lovely, actually having people go and do more than what they could do to begin with. So I think that's always a lovely thing.
Yeah, we've had some people near enough double their activity levels, whether that be their running distance, the amount of times they go out for a walk. It's been, I think that just then really highlights to us around about the education as well around, and the expectation management around these plantar fascia, these Achilles tendon issues, that we do just need to make sure that everyone's getting educated along the way, so we know what it is, and then we can put things in place, whether that be exercises, footwear, whatever, to try and reduce the risk of then this happening again. So let's move on to tarsal tunnel syndrome, as it were. So Charlie, what is tarsal tunnel sort of syndrome, or let's call it, as it were?
Yeah, so within the ankle joint and the way that the ankle moves in relation to the foot, there are bones that come and meet together, and they create this kind of tunnel effect that sits from it looks like you're going through the foot. And what that can sometimes do is repetition or overuse of the joints can then create this kind of swelling and fluid build-up in this area. And then that can put pressure on the nervous system and can put pressure around the soft tissues that creates pain and symptoms.
Yeah. And then how would that present? So if someone's coming to clinic and we think, oh, this may be tarsal tunnel syndrome, what symptoms would someone expect to be getting?
You sometimes get a sharp pain that can last a couple of minutes, tends to ease when you're stopping or not doing the movement pattern anymore. Sometimes there can be a kind of a dull ache if it's more towards at the end of the day. You may notice some heat and swelling in and around the ankle area. You may find that you get discomfort on kind of extreme ranges of moving the ankle joint itself.
Yeah. And then also you may then also get some numbness around the inside of the ankle as well. I think this answer is going to be quite quick, but Natalie, exercise-wise, tarsal tunnel syndrome, what do you try and do?
Nothing.
Yeah,
Can't do anything.
No, I agree. There isn't really a lot I don't think you can really do rehab-wise for tarsal tunnel. If this nerve is compressed, it's compressed. If it's a sort of mechanical overloading, and we can try and offload it with foot orthoses, and we can have a chat about that in a second, Charlie. But yeah, I think a lot of the time is, if you can't offload it with foot orthoses and footwear, then it's maybe looking at referring on for an injection, and then possible
it's quite extreme, isn't it? Not any like kind of friendly outcomes.
no it is. They speaking to some of the surgeons we work with, they tend to get some good results with injection, but I think it all depends on, is the nerve compressed, is it trapped in some way, it's why are they getting the symptoms. So what are your experience with using foot orthoses and tarsal tunnel?
I'd say probably 50-50. When they work beautifully. When they don't, off to orthopedics is probably the best and kindest thing to offer. And again, I think that's probably where using something like an MRI image is really helpful to really understand what structure is being irritated, and really targeting your treatment plan to make sure that you're addressing that. And within this clinic, we know that we're best suited to referring on to our wonderful colleagues who can then take over that management and make sure that the person gets the care that they need. Yeah,
I completely agree. Now that there is another random one that I think people may find interesting. You can, obviously, because you've got a heel bone, you can fracture that heel bone. and you if you jump from a height and land on your heel and you get a fracture, the fracture you get is sometimes called lover's fracture, and I'll let people try and work out why is it called lover's fracture if you're jumping from a height. But I'm not joking around. That is the true name of that diagnosis, of that fracture you can get in the heel bone. Yeah, maybe we won't chat about stress fractures or anything, because that may bring back
Too upsetting.
it's too soon for Natalie to talk about stress fractures.
Yeah.
We could talk about severs.
Oh yeah, well yes, I'm really sorry. I just
I'm ready for this.
Got a tick for me.
Once she's excited to speak about it, we just massively forgot about it. And I've even got everything planned in front of me, and I still managed to mess it up. So Charlie, talk to us about severs.
Severs is a term used where the growth plates within the calcaneus, that's your heel bone, haven't completely gone through their formation into kind of matured bone. So what you tend to find is you get the growth plate is slightly softer, I guess, and more malleable with having its attachment. So the Achilles and the plantar fascia coming and attaching around that area. And so you tend to find it's in younger persons. So anywhere between as young as 8 to as old as kind of 14, 15 is what the literature indicating. And they often complain of kind of pain. It's worse on activity. It tends to be that it does ease when they're not doing any activity at all, but actually it's all the emotional bits that go around with it. It tends to stop people doing what they love doing. Although if you want to get out of PE, great thing to have, but it does kind of stop people from living that active lifestyle. In combination with that, you tend to find the Achilles tends to be quite tight, and it tends to then disrupt kind of normal movement patterns in the lower limb, which tends to be when they come to wander into our clinic.
Yeah, and the reason why I lumped it together with that insertional Achilles tendon, it's not an insertional Achilles tendinopathy, because in my opinion, if you see a true tendinopathy in a child, that's almost a flag to refer on to rheumatology, because the beauty of things are kids, their tendons are so flexible and malleable, you can do a lot to them and you won't generally aggravate them. You may overload them, but they'll settle really quickly, and everyone remembers what the stuff you used to be able to do when you're a child. You used to be able to get away doing whatever sports and activities you want to do, and you get up the next morning and you feel absolutely fine. You then hit the magic 4-0 and then you get out of bed and you can't. You just find that you're just a little more stiff and things take a little more time to get going in the morning.
We're not there yet.
Yeah, we're not fine. What joys to look forward to.
But yeah, I think it is, the reason why is because the management tends to be quite similar, i.e. you tend to look at a heel raise. A lot of people always try and stretch severs, and a lot of the time, sometimes I have tight calf muscle, but sometimes they won't. And I'm always of the opinion, if the calf muscles aren't tight, why are you stretching it in the first place?
I think it's a lovely condition that we can do lots with and really get symptoms settled quite easily. So in my head, I'm like, oh, that's one that's really, really great, because we can get the person comfortable fairly quickly and then back to activity as soon as possible.
And I think the good news is that the majority of them, like I would say a high 90% of severs cases, or calcaneal apophysitis to give it its proper name, is self-limiting. They will resolve on their own. It may take a couple of years, but they will all tend to get better. And the good news is the majority, if you continue to hurt and overload it during football at school, the reason I say football, the most common type of patient I see personally in clinic are 12 to 14-year-old boys playing football in the summer months when the ground gets hard. It's the most common time that I'll tend to see it in clinic. But the good news is you're not really going to do any damage or issues to it. So if it hurts, just offload it. But you can go back to doing it. You're not going to cause any lasting issues. And quite often you're just giving them a heel raise in the shoes. How often do you have to then look at intervening with foot orthoses with this?
Very rarely. So I tend to give a heel raise with some loading, depending on what their clinical assessment findings are. And then I like to get them back in kind of a month to 6 weeks' time. And if everything's starting to settle and they're off doing what they should be doing, then they're free to carry on.
But I think a lot of the time it's then handing over to Natalie to then start with that rehab, because you'll tend to find when we sort of see those sort of teenagers in clinic, how many of them are doing any sort of regular strength stuff in relation to the amount of sport and activity that they're playing?
Barely any.
Yeah.
I don't think, maybe the odd one do sort of squats, but
Because when you speak to them, a lot of them, they're like, you'll speak how much activity you're doing, and they're, well, I PE twice a week. I'll run around the playground for an hour at lunchtime.
yeah, it's huge.
Then
that
I'll have
load.
after school football. Then I'll have some badminton and athletics, and then I'll have 2 football matches. And you look at it, you're thinking they're doing huge amounts. I
Yeah.
think a lot of it is just having a quiet word with them and the parents, saying, okay, let's wind this activity level back, get you stronger, and then build
Yeah.
that activity.
Yeah.
I think
back
as well,
again.
though, when you're that age, it's more like hobbies, isn't it? You don't see it as exercise because it is just fun, and
Yeah.
you just want to do as much as you can. So
Yeah,
But
I
yeah.
was exactly the same. I used to do my paper round and then go cycle the paper round with my paper bag and my hockey bag, then go play indoor hockey before school, then have PE at school, then have hockey training after school, and then do football training after that, all in one day. And I'm thinking, no wonder from time to time we sort of picked up a few, because I was looking back and I think I was just doing far too much.
Yeah.
Was I doing any strength training or any exercises to work? No, I wasn't doing
You're
any
playing
of
on the PlayStation, laid on the sofa.
that. Yeah, it's literally either out and
Meant
about.
to be doing homework.
You sum my childhood up in one. So, is there anything else? Because I clearly missed speaking about sevens, even though it's in front of me. Are there anything else that you guys want to mention that I've missed?
No, I think it's having the remembering the simple things, like you can have contusions of the heel, which is bruising.
Yeah.
You can have the blister formation. So it's all the simple things as well, just to be mindful of. It's not always the most extreme that you'll see out there.
yeah, no.
So let's sum up with sort of 3 tips from all of us. So if you're looking at sort of general foot and ankle pain, Natalie, sort of 3 things from an exercise rehab perspective that people could be start doing to try and reduce the need for people to come to see us.
Yeah, so again, it's loading, starting those heel raises, going to single leg heel raises. I can't, emphasize how important that load is.
Yeah.
My second tip would be to look at your load, and it's the hidden load what we've spoken about. So just, writing down what you're doing in a day and actually, seeing if it is too much. And then, using that with the exercises and sort of set yourself a maintenance program, more like a rehab if you don't have any niggles yet. And then just keep to it sort of once or twice a week, and then really focus on those big muscle groups.
Perfect. Good stuff. Charlie?
I think mine would probably be looking at footwear. Is it specific for the activity that you want to do? And if you're going to change it, make sure that those changes aren't extreme, that they're gradual changes. And then I think it's just that mindfulness that orthosis doesn't cure everything. They have their place within our practice, but actually it's making sure that your knowledge around what is wrong with you is specific so that you get the outcomes you wish to achieve.
Yeah. See, again, this wasn't in the scripts, and I've sort of asked Charlie and Natalie to give 3 tips, and I've left myself to last. So for me, it would be, remember, we are all different. So if you got an injury, the treatment that Karen on Facebook has had isn't going to be the same that the journey that you may go through, because the injury may be different. So yes, groups on that can be helpful, but it's also remembering that it's your problem, it's your pain. So it's getting the right help when you need it is the second tip. And a lot of the time I tend to find if you can get help sooner rather than later, sometimes you can then try and help speed that process up back to activity. And I think finally just be prepared that it's going to take time and things won't always go to plan. So always say to people, when you're going through rehabilitation and treating injuries, they'll have good days, you'll have bad days. But as long as you've got someone in your corner to help keep you, pushing you forward and motivating you, then I think that's always a good thing. And then sort of a bonus tip, as it were, that I also think with regards to stuff like this, is pain isn't necessarily always a bad thing. So if you're doing some exercises and things feel a little sore and a little tender, that's completely fine. If you wake up the next morning and everything's settled, then that's completely fine. As we say to all our patients, when you're doing your exercises, it may be a little uncomfortable, maybe a bit of discomfort, but as long as everything's settled by the morning after, we're not too bothered about that. So I think that sums up everything nicely. So I just want to thank you, Charlie, for coming.
By the way, who's Karen?
Just a random name.
Just a random name.
Yeah, just a random name.
Joe Bloggs.
Yeah, it's just sort of just a random name.
Sorry.
Yeah, I don't know. Yeah. So and then thank you, Natalie, for coming on.
Thank you.
Whatever platform you are listening or watching on, don't forget to comment and subscribe, and just leave us some comments on what you want the next podcast to be. Do you want us to have a discussion with someone like Amy from SO51 Fitness, a local gym in Romsey, and possibly a local running coach as well? Or do you want us to have a chat about calf and Achilles problems? Just comment, let us know, and we shall see you all next month. Goodbye.